This is a video summary of risk of myocardial infarction at specific troponin T levels using the parameter predictive value among lookalikes PAL by Ola Hammarsten and co-authors. The clinical utility of a biomarker is often evaluated using binary classification that result in a fraction of patients with or without the disease below or above a given biomarker level. Examples are sensitivity and specificity, where the patients with or without disease are analyzed separately, and negative and positive predictive values, where patients with and without disease are analyzed together. A problem with these calculations are that they fail to adjust for disease prevalence. Although this can be done using likelihood ratio, a general problem with all binary classifications are that they use the fraction above or below the biomarker level in the calculations. Binary classification, including likelihood ratio, therefore fails to estimate the risk of disease at a specific biomarker level. As in this case, where the probability of disease is 80% above the biomarker level, but only 50% at the biomarker level. The cardiac-specific biomarker troponin T is released in response to cardiac damage and can be measured in patient blood following myocardial infarction. Unfortunately, most of us has a low but measurable level of troponin T due to non-specific leakage from the heart. Clinical judgment is therefore required. An emergency room physician assessing the result of troponin T in a patient with chest pain is often occupied with two questions. If I exclude using the troponin T level in my patient, what fraction of patients with myocardial infarction will I miss? The answer to this first question is simply 1 minus sensitivity at the patient's troponin T level. That is, the fraction of patients with myocardial infarction presenting with troponin T levels below the actual patient's level. The second question, at the patient level of troponin T, what is the risk of myocardial infarction, is more complicated. To answer this question, we must calculate the risk at the patient's troponin T level. In addition, we must also adjust for pre-test prevalence, that is, the fraction of chest pain patient that has myocardial infarction on this emergency ward. This can be done using the novel parameter predictive value among lookalikes, PAL. The principles of PAL is to use the fraction of patients with or without disease within a biomarker range using delta sensitivity and delta specificity within this range. If the patient's troponin T level is within this range, the risk of myocardial infarction can be estimated. To adjust for disease prevalence, the odds for not having the disease, the beta factor, is included in the PAL equation. The lower the disease prevalence, the larger the beta factor. It is possible to analyze how PAL changes with biomarker levels in PAL plots. We use biomarker ranges based on percentiles to make sure to include a given percentage of all the study data in the PAL calculations. This was done in order to avoid large variations in PAL when the number of patients become close to zero at the low or high end of the dataset. PAL plots can be used to evaluate how PAL change with biomarker levels and to estimate PAL at specific biomarker levels, as is shown here with the red arrows. It is also possible to plot PAL against 1 minus sensitivity. The resulting PAL plot behaves like a ROC plot. The advantage compared to a ROC plot is that the PAL data on the y-axis are affected by pre-test prevalence, and that the data on the x-axis describes the risk of missing the disease. The plot becomes a combination of the clinician's two questions and visualizes the interplay between risk of disease and the fraction of missed diagnosis at different biomarker levels. We evaluated the clinical utility of the troponin T test on chest pain patients from our emergency ward. As can be seen in these plots, troponin T levels overlapped in patients with and without myocardial infarction. As expected, the overlap was more prominent in older patients. In accordance with this, ROC plot analysis indicated a lower clinical utility of the troponin T test among older patients. Using PAL plots that adjust for the fact that older patients had a 4.6-fold higher pre-test prevalence of myocardial infarction, it was evident that the clinical utility of the troponin T test was more similar in these two age groups. Non-specific troponin T elevations causing a significant overlap among older patients is in part balanced by a higher pre-test prevalence of myocardial infarction in these patients. According to the PAL plot, the troponin T test appears to distinguish patients with or without myocardial infarction similarly at different ages, a fact not visualized by the ROC plot analysis.